maxillary central incisor, the average length of this tooth is 22.8 mm. Pulp chamber. The pulp chamber of the maxillary central incisor is located in the center of the crown, equidistant from the dentinal walls. It is broad mesiodistally with its broadest part incisally. The pulp chamber usually follows the contours of the crown and has three pulp horns that correspond to the developmental mamelons in the young tooth. The chamber is ovoid mesiodistally. The division between the root canal and the pulp chamber is indistinct. The maxillary central incisor has one root with one root canal. The root canal is broad labiopalatally and large and simple in outline, conical in shape, and centrally located. A definite apical constriction is present in the mature root canal. In cross section, the canal is ovoid mesiodistally in the cervical third, ovoid to almost round in the middle third, and round in the apical third. The lateral canals may be present, 24% of the specimen, usually in the apical 1/3. Although the majority of the roots are straight, some may curve distally, mesially, palatally, labially. The root canal usually follow the direction of the curved root. The palatal and labial curvature may not be seen in the routine radiograph unless a radiograph are taken at different horizontal angulation. The apical foramen is centrally located in the anatomic apex in only 12% of the cases, and apical delta is present in 1% of the cases. As far as the anatomical relationships in situ, the labial surface of the root of the maxillary central incisors lies under the labial cortical plate of the maxilla and may fuse with it. Because of the proximity of the labial root surface to the cortical plate, fenestration and dehiscences may be present, and abscess may perforate the labial cortical plate. The relationship between the apex of the maxillary central incisor and osseous plate in the floor of the nasal cavity depend on the height of the face and the length of the root. Usually, the nasal fossa and the root apex are separated sufficiently that curettage of the granulomatous tissue within the surrounding cancellous bone does not result in perforation in the floor of the nasal fossa. In some patients, the apex of the root is close to the nasal floor, so an abscess may drain into the nasal fossa or a cyst may bulge into the inferior nasal meatus. The maxillary central incisor has an average of 2 degrees of mesioaxial inclination and an average of 29 degrees of palataloaxial angulation in its alveolus. The incisive canal parallels the long axis of the maxillary central incisor. The long axis of the tooth serves as a guide for the palatine injection. One should align the barrel of the anesthetic syringe parallel to the tooth and insinuate the needle alongside the papilla. As far as the access opening is concerned, the shape, size, and coronal extension of the pulp chamber are estimated through the diagnostic radiograph. The internal anatomical structure of the pulp chamber of the maxillary central incisor dictates the shape and size of the access opening. The enamel is penetrated in the center of the lingual surface at an angle perpendicular to it with the number 4 round burr in high speed quadrangle. After penetration of the enamel, a number 4 round carbide burr in a slow speed quadrangle is directed along the long axis of the tooth until the pulp chamber is reached. A drop of the burr into the chamber may be felt if the chamber is large enough. The overhanging enamel and the dentine of the lingual surface of the pulp chamber are removed, including the pulp horns with a number 4 round burr in a slow speed quadrangle by working from the inside to the outside following the internal anatomy. This procedure makes the access cavity walls confluent with the lateral and the incisal walls of the pulp chamber and renders the access cavity a lingual extension of the pulp chamber with a straight line penetration into the apical root canal. A gate Glidden drill of appropriate size is used to remove the lingual shoulder by working from inside outside with a light strokes. The lingual shoulder is not an anatomical entity itself, but rather prominence it's a prominence of the dentine created when the lingual roof is removed. By removing the lingual roof and the lingual shoulder of the pulp chamber in an interior tooth, one gains direct access to the apical area of the root canal. Direct access can be verified by placing the straight end of the endodontic explorer into the canal orifice. The explorer should follow the path of the canal without impediments from the walls of the surrounding access preparation. The shape of the access outline form for all anterior teeth should reflect the shape of the internal anatomical structures of the coronal pulp chamber of each tooth. In maxillary incisors, the access shape is slightly triangular with the base of the triangle toward the incisal edge. The usual anatomical structure of the chamber and the root canal in any tooth can be altered by the deposition of reparative secondary dentine, a response often associated with trauma, caries, restorative procedures, or aging. The pulp chamber of these teeth may be reduced in size or completely calcified. Access preparation can be made as described previously with the following modification. Penetration the enamel in the center of the lingual surface of the tooth at an angle perpendicular to it with a number 2 round carbide burr in a high speed quadrangle. After penetration of the enamel, change to the number 2 round carbide burr in a slow speed quadrangle and direct the burr along the long axis of the tooth until the reduced pulp chamber is reached. Enlarge the enamel portion of the access cavity to an ovoid shape with the greatest diameter incisogingivally. Change to an appropriate size gate Glidden drill and working from the inside to the outside of the chamber funnel the dentinal walls. The access preparation is completed when it is funnel shaped, smooth and continuous with the radicular portion of the pulp cavity and when it provides straight line access to the apical third of the root canal.